Good evening. While doing the rounds, we saw this. This patient had received IV thrombolysis the day prior to this, and the hand there was a hematoma. Took an X-ray is normal. We thought this is a complication or a side effect of IV thrombolysis in acute stroke. Welcome to another episode of Stroke Rounds. I am Dr. Gigi Kuritukulam, stroke neurologist at Rajagiri Hospital, and along with me is Dr. Jithin Antony, who is doing his fellowship in stroke. This is another patient who, after IV thrombolysis, had hematomas in and around the eye. Another patient, Jithin, would you like to comment more on this?
This is orolingual angioedema, or it could be an hematoma. So usually orolingual angioedema occurs contralateral to the side of the infarct, more common in patients who are taking AC inhibitors. And the confusing thing, it could be a hematoma or an angioedema. We have to take a CT tongue if it is growing in size to distinguish whether it's a hematoma or it's truly an angioedema.
How common, Jithin, do you think angioedema is there after IV thrombolysis?
In literature, it says around 1 to 8% of patients can have orolingual angioedema, especially if they are taking AC inhibitors and when they receive alteplase.
How many you have seen in your practice?
Maybe 1 or 2 only.
Yeah, it is very uncommon to see an angioedema, but always we should keep that in mind. What are the problems with an angioedema?
Airway compromise can occur, so you have to act swiftly. If there is an airway compromise, you have to go with the routine steroids, IV ranitidine, and if needed, an IV epinephrine. So securing the airway is of prime importance in these patients, and you have to distinguish whether it's a hematoma or an angioedema.
So the take-home point is, suppose if you thrombolyze a patient and in the middle of the night you get a call from the ICU saying that the patient is having difficulty in breathing, immediately think of this possibility, whether this could be a angioedema after IVT. So securing the airway is the main aim of treatment, and along with other modes which Dr. Jithin has already mentioned. What is this?
It's a flank hematoma. It could be GI bleeding, external manifestation of a GI bleeding.
And more important in a patient who has received IVT?
It could be a retroperitoneal hematoma.
So this is the CT scan showing a retroperitoneal hematoma. What is the clinical problem with the retroperitoneal hematoma? Even with such a large amount of bleed in the retroperitoneum, the clinical signs outside may be very, very subtle. So what are the usual clinical signs of a retroperitoneal hematoma?
There could be hypotension.
Usually one of the commonest problem will be hypotension. The patient becomes pale, which many times we will fail to recognize. The patient develops hypotension, the patient collapses, and when you look, the patient has become pale, and there is a drop in BP. And then when you ask for a routine investigations, the HB is significantly low. A large amount of blood can collect in the retroperitoneum without any obvious abdominal swelling. So these small signs like flank, any ecchymosis or change in color should be carefully looked into. So what should be the investigation in such a situation?
It should be a plain CT will.
Yeah, many times now we do an ultrasound abdomen, but ultrasound abdomen can miss technically a retroperitoneal hematoma if it's very small. So if you are doubting a retroperitoneal hematoma, always
CT scan.
So this should be considered in patients who after IV thrombolysis has got a significant drop in hemoglobin, the patient develops hypotension, the patient is pale and the patient is collapsing, and you don't find any other source of bleed, then definitely the possibility of a retroperitoneal hematoma should be considered. What is this CT scan showing?
The picture A is showing a dense MCA sign.
So there is a dense MCA sign, the patient has got a dense MCA sign. What else do you see here?
There is a periorbital swelling, collection, could be a periorbital edema.
And you see a retroorbital bleed also. So the patients, when there is a unilateral swelling of one eye after IV thrombolysis with the eye which is bulging, always think of the possibility of a bleed in and around the eye. So this can be another complication. What is this?
It's a parenchymal hematoma.
It's a parenchymal hematoma which can vary in size depending upon patient to patient. So it can be quite large or just a hemorrhagic transformation. So these are, would you like to explain more on this?
So HI is hemorrhagic infarct, that is transformation of infarct into hemorrhagic infarct. The other one is PH1 is parenchymal hemorrhage. So ECAS has divided this into H2, then is H1 and H2 and PH1 and PH2. H1 is just small petechiae along the margins of infarcted area. H2 is little bit more confluent petechiae around infarcted area. There is no mass effect in that. PH1 is hematoma size less than 30%. PH2 is hematoma more than 30% of infarcted area with mass effect.
So what is the significance? What is the difference? So there are two entities. One is hemorrhagic transformation or hemorrhagic infarction and parenchymal hemorrhage. Parenchymal hemorrhage is significant. That means it is space occupying, it is producing mass effect, it might produce herniation, and the patient needs immediate, probably decompression. Whereas a hemorrhagic infarction, what does it mean?
That the vessel has opened up.
So usually it is a sign of reperfusion. And usually it is, unless there is a significant mass effect, it needs only conservative treatment, decompression. Why there should be a classification for this? Because when you are doing a study, you want to publish something, there should be an unanimity in communication. So when you talk about a post IVT hemorrhage, it should be very clear whether it is a hemorrhagic infarction H2 or a parenchymal hemorrhage PH2. So when you say it is PH2, we immediately know that it is more than 30% of the infarcted area with a notable mass effect. So as far as possible, try to use this ECAS classification of hemorrhagic transformation when you describe complications after IVT. What is this?
This could be...
This is a patient who underwent mechanical thrombectomy. Successful recanalization, patient is doing extremely well. Immediately after the mechanical thrombectomy, a CT scan was done which shows this. What is this?
It's a collection of contrast known as
contrastoma. So this is called contrastoma. So this is a significant collection in that area. No mass effect. The patient is doing extremely well. There is no deterioration. Power is normal. The patient has actually improved. There is no mass effect as such. So how will you differentiate this from a bleed?
Usually it resolves with
So the
time.
first is clinical. There is no clinical deterioration. The patient is doing well, no headache, no clinical deterioration in neurological power, but there is a small area of abnormality like this. Second,
in repeated scans it will show clearance.
24 hours later, repeat a scan, the whole thing will disappear. Suppose if it disappears that fast, it has to be contrast. And if you look at the Huntsville unit, this you can find that it is corresponding to that of contrast, which is different from that of blood. Now, how, since we are discussing too much about the complications, how common is a complication after IV thrombolysis?
Harmful complications are only very less, out of 3 in 100.
So this is a very famous diagram, which is discussed in many forums. So if you treat 100 patients, you have 3 patients, and out of that 1 might die because of IV thrombolysis complication. 3 might have a significant hemorrhagic transformation or parenchymal hemorrhage which needs attention or treatment. So rest 32%, 32 people. So if you treat 100 people, 32 will benefit, 3 might be harmed. So this is an accepted thing. So nobody should be scared of these 3 patients and not doing that. We were discussing about this. Many a times, most of the neurologists, many of us are actually much more worried about the small percentage of patients who might develop a hemorrhagic transformation or parenchymal hemorrhage than this 33% who might benefit from IV thrombolysis. So this should not be a deterring factor from using IV thrombolysis. There are so many treatment guidelines which are available. So in the next sessions, we will try to address one by one how to manage when there is a patient with intraparenchymal hemorrhage. Second, suppose if there is a patient with GA bleed, how to manage that. How to manage a patient with retroperitoneal hematoma in the subsequent sessions. Thank you for your comments. Please don't forget to leave your comments, suggestions, and if you have any opinions, please do let us know. And do subscribe to this channel and click the bell icon also. Thank you.